Thank you. Now we will take you a few minutes for a video presentation of our university. for the official opening of the meeting, I would like to invite Mr. Kocaeli to the microphone, please.
Good morning, everyone, and thank you for the honor. Professor Jantar has been a friend of ours for many years, and Turkey feels like a second home, coming back to all familiar faces and friends. For many years we've been coming here, and I thank you again for the honor of allowing West Global to co-host this conference with the University of Kocaeli. West Global, as you know, and I'm West Global, we started off with an idea in COVID, but we found that all of us had nothing to do. We had lots of time on our hands and nothing to do. We had lots of big ideas and we wanted to communicate. So we came across this educational platform that was online, and webinars now have become a passion. But it's good to meet face to face, because this is more important than the webinars. I think the webinars have their place, but this is more important because of the interaction, because of the networking, the idea exchange, meeting colleagues, making new friends. It's always interesting to meet in person than in webinars. They have their place. It's a very interesting meeting. You have a very good faculty. I'm looking forward to the meeting, so I welcome you all. I invite Professor Jantar to officially open this conference. Thank you very much.
Thank you. Now, for the opening, I would like to invite you, our rector, Professor Mustafa Cantik.
Dear colleagues, today, with support of West Global, the Turkish Federation of Breast Disease Societies and Society of Breast Surgeons, we as a senator and Kocaeli Breast Disease Research and Treatment Association are organizing 7th Mayday, which is traditionally organized every 2 years at Kocaeli University. The topic is novel techniques for management of breast cancer. The meeting will be in English. For international participants, the 2-day meeting will be broadcast live on the YouTube channel. A large number of international and Turkish speakers will contribute to the meeting. On the second day of meeting, a workshop on breast ultrasonography and interventional procedures will be held under the name of Mini Senological Ultrasound Course. Breast cancer is highly prevalent type of cancer worldwide. The management of breast cancer has evolved significantly over the years with the advent of novel techniques that have improved patient outcomes. We will discuss some of the latest techniques that are being used to management of breast cancer. First, I want to tell why we selected this topic. As you know, treatments for breast cancer is escalating day by day. As we also know, surgeons are logical men or women. So they will find their ways and will change their practices. As we all surgery is changing to minimal invasive procedures, a few years ago in Istanbul, I was a speaker in a meeting early in the morning. Before my presentation, they talked about the personalized treatments and explained how fast change and progress chemotherapy, hormonotherapy, and immunotherapy. Yes, it was right. Everything changed fast, but I believe surgery will keep its place as ever from Hippocrates. What I mean is that radiology, pathology, and oncology are going to the end. Radiology is changing artificial intelligence with an equipment will detect the lesions. We will not need the traditional pathologists because of new methods like a liquid biopsy. And whenever we diagnose the cancer, we will learn from AI such as ChatGPT which chemotherapeutic drugs and which doses of these drugs are recommended, and we will ask nurses to infuse them. We also know human beings will not let any robots to operate or disturb their bodies. As we know, patients want us to touch them and show empathy to their situations. It is not possible with robots or AI. How do I know this? Yesterday, I asked the ChatGPT, how are you? It replied, that it has not any sense to respond to this question. This is a joke. As I told that the management of breast cancer evolves year by year, the advent of novel techniques improves outcomes. Some of the latest techniques that are being used for management of breast cancer are as follows. Genomic testing is a revolutionary technique that helps in determining the likelihood of breast cancer recurrence. It involves analyzing genetic makeup of breast cancer cells to identify the presence of certain genes that may increase the risk of recurrence. This information helps in developing personalized treatment plans in patients. Targeted therapies are drugs that are designed to target specific proteins and genes that are responsible for promoting the cancer growth. These therapies are highly effective in treating certain types of breast cancer, such as HER2 positive breast cancer. Immunotherapy is a novel technique that involves using the body's own immune system to fight cancer cells. Precision surgery involves making accurate incisions to remove breast cancer tumors while preserving as much healthy breast tissue as possible. This technique helps in reducing the risk of deformity or scarring and also improves the cosmetic appearance of the breast. Minimally invasive surgery involves making small incisions to remove breast cancer tumors. This technique results in less pain, scarring, and downtime for the patient. Cryoablation yes, it is well. Cryoablation. Today we would host a company. They will explain the cryoablation for breast cancer, but they are not here. They have promised me they are not here. I am sorry about them. I wrote to companies and the speaker. Western usually promise and do it. They are from Israel. But Eastern rarely do it whenever they promise. Cryoablation is a novel technique that involves freezing cancer cells to destroy them. It is a minimally invasive technique that has shown promising results in the treatment of small breast cancer tumors. Integrative therapy involves using the combination of conventional and complementary therapies to manage breast cancer. This approach helps in reducing side effects and improving overall quality of life for patients. As a conclusion, breast cancer management has come a long way with the advent of novel techniques. These techniques offer hope and promise for better outcomes for breast cancer patients. So we decided to make this organization. At the end, I would like to appreciate colleagues from abroad for accepting our invitation and being us. It is our pleasure to host you here. My special thanks to Ash and Yazan for their warm friendship. They have supported and encouraged me for the same. I also thank the colleagues from Senator, Turkish Federation of Breast Disease Societies, Society of Breast Surgeons for their contribution and support. I am also grateful to become this company back in generosity and being here together. I also thanks to organizing the agent and deputies, including my assistants, drivers, technical team, IT team, for their efforts to make this meeting successful. I wish all to benefit. This meeting will be beneficial, and I hope you will have a safe. Thank you very much. I thank you all of you.
Thank you. And for the next session, I would like to invite the chairs, Professor Dr. Kutladığımız and Professor Can Atalay. Thank you.
glad that you are here in our university, in our faculties. Well, there are three speakers in the session, and I want to invite the first speakers, Dr. Mark Thiel. His topic of conversation is it time for the wire to retire?
Dear colleagues, ladies and gentlemen, first I can't believe everyone. It's really an honor to be in Kocaeli the first time to attend the 7th International Breast Mayday. My name is Professor Mark Thiel. I'm a gynecologist in Germany. They treat breast cancer, so this is my passion and this is the reason why I'm here today. And I try to answer the question, is it time for the wire to retire? I want to talk about novel localization techniques. So these are my conflicts of interest. I do have several ones, but this is due to the fact that we have a lot of corporations and a lot of trials running in my department. And this is German data. So data from last year about the incidence of non-palpable breast lesions. As you can see that 56% of all surgery primary cases in Germany are consisting of a T1 tumor or ECIS. That means a lot of patients having a non-palpable tumor. There are a lot of patients where we have to identify in the OR and we have to detect the lesion to make a proper resection. And this is data coming from the 220 certified breast centers we have in Germany. So we all know as breast surgeons, if the lesion is not palpable preoperatively, it must be localized. It must be localized by an imaging guided label such as wire marking, and it has to be extirpated according to this marking. And you see that wires are used in the breast and clips are used in the breast, clips before neoadjuvant chemotherapy. Maybe if you want to clip an ultrasound, use a preoperative wire localization. This can be done, of course, in the maxillum tumor as well. The question is this gold standard? And when we take a closer look to what happened during the past years, then we see that a lot of clips and a lot of calls were used to identify where is the lesion, to find the lesion, and to make a proper resection. There are a lot of trials that I don't know what clips you use. We use tumor vision clip because this is quite easy to find because it's like a ring in the ultrasound. And for the reason that we use ultrasound during the operation, it makes it easy. So what we are using, we use
One, two, 1, 2. Oh my God. I'm frightened to hear my voice that loud. Well, okay, makes it easier for me so I don't have to shout and you can listen properly. Okay, yeah, coming back to the wire marking. So we need wires because you're lost in the breast. I mean, imagine you have a D-cup-sized breast and then you have a lesion of 10 centimeters. You want to perform an oncoplastic tumor-adapted mammoplasty, and then you don't find the lesion. You need 3 wires and maybe not only wires. So advantage we take out of the wire marking is that this is long established. It's recommended by so many guidelines. Localization is carried out on a technically high-quality device. It's suitable for imaging modalities, mammography, ultrasound, not always for MRI because the wires, they may disturb each other. And mammography correlation is possible after ultrasound-assisted wire marking. But there are disadvantages like scheduling. I don't know how you do it, but we cannot do a patient undergoing a wire marking in the first position of the aura plan. And diagnostician must be in the house or the patient must be transported to him. Usually we invite the patients the day before, and then the patient is sent back home with a wire in the breast, and this is not really comfortable because it's an invasive technique. And as I said, it's inconvenient, unpleasant for the patient. What else is there? If we ask, is there something beyond the wire? And my dear colleague, who is a member of my board of directors of the AWGYN, Maggie Banes-Polechowski, she did a really good job and summarized what else is there. I want to talk a bit in detail about probe-based, about the wireless localization techniques. But of course, there's clips, there are radioactive seeds that are not used in every country. Of course, you can use ink, but then it's a problem to detect the ink. Radar localization, we'll talk about magnetic seed and radio frequency identification devices. This is a chart, this is a slide of our AGO guideline recommendations. I don't know if you're familiar with them, but there is a German version, there's an English version that is free to download from the internet. So this is our treatment recommendations of the Association of Gynecological Oncology. We re-update these recommendations every year, and the recommendations are supported by my association, by the AWGYN. So before we talk about wireless marking, I think we have to talk about what else can we do in an easy way to identify the lesion, to identify maybe the clip, and this is intraoperative ultrasound. And of course, there's a little asterisk down there and it says that the lesion must be sonographically visualized by the same examiner, so therefore I would recommend that the breast surgeon who does the surgery the next day or the same day has to have an idea where is the lesion, where is the clip, and it's the best thing to identify the tumor before on its own. And this is recommended with a double plus. Double plus is the highest recommendation grade we have in our AGO guideline. That means you have to do it. Plus means you can do it. Plus minus means decide on an individual base, and then minus and minus minus in the end you harm the patient. Yes, we can identify lesions via clip marking. Yes, we can improve the reoperation rate, so we can decrease reoperation rate by using intraoperative ultrasound. But to my understanding, intraoperative ultrasound is nice to have. There's a really proper paper that was published a couple of years ago by Wolf Eggemann, a German colleague of mine, who identified a free margin in ultrasound of 4 millimeters will lead to a significant decrease of the reoperation rate. But in the end, it's just imaging, and you are not detecting cancer cells on a cellular level, so then you have to use other techniques. This is one of our background slides. It just shows you that there are meta-analyses, there are studies that have been published, and that ultrasound-guided surgery has a potential benefit to decrease the reoperation rate. 18 studies, more than 3,000 patients. I think this is a really big piece of evidence. But now we try to answer, is there something beyond the wire? So we want to talk about wireless localizations. And again, the same slide from our AGO slide deck, and it says there are other procedures. There are the procedures I just talked about and mentioned before, radar reflectors, magnetic seeds, radio frequency-based markers, and radioactive seeds. And as you can see, the recommendation rate is a plus minus. Why? Because we don't have consistent data that all these techniques were compared in prospective trials against the standard of care, the wire. And we don't have head-to-head comparisons for the fact that this is quite new. So therefore, you are able to do that, but you don't have to choose one of these as your favorite technique. You can use all of them. So this makes the recommendation rate a plus minus. So this is a little video. I hope that, I know that it goes. I just wanted to show you the, oh, there we go, sorry, go back. Maybe you can click on the video, thank you. It just gives you an idea. So this is the serious pintuition marker, and you hear the sound, and there you have the little console, and you see there are the millimeters, and so it's like a navigation system. You don't have the wire, you have to identify via ultrasound. You don't have the wire you have to make your preparation along the wire, and you know that this is sometimes really inconvenient because the wire comes from the side and your lesion is on the other part of the breast. So therefore, this is like a navigation system, you know, maybe from parking your car. And this is one of the magnetic markers we have at the moment in the market, the series Pintuition. This is a magnetic seed. We have the MAC seed by Endomag, and all these techniques, they can be detected intraoperatively by a magnetic probe. This is approved for breast and axilla, so you can use it for breast lesions and for lymph nodes. And of course, the advantages are, of course, no wire localization that is necessary, transcutaneous measurement, no signal loss over time, and nickel content very low for all people who have nickel allergies. But you can produce MRI artifacts, so this is something that is taken into account if you make a monitoring via MRI under neoadjuvant chemotherapy, for example. And metal instruments are not recommended during the operation because metal instruments, of course, make the same signal, so therefore you have to use plastic instruments. And this is just an example of the MRI artifact that can be generated. So this is on the right side here. So we use MAC seeds in the lymph nodes. Thorsten Kühn will talk about that for long-term marking. This data is published. We had no migration, so this is very easy. So this is the needle, and in the end, this is the MAC seed, and it's very easy to do. So therefore, just try it out. There is a publication out from the IBRA net localization study, 2,300 patients, MAC seed versus a wire, and the authors concluded that the lesion identification rate was high with the MAC seed. We don't have always these studies where the new tool is compared with the standard of care, but the number of these studies is increasing. What else do we have? We have radio frequency markers like the localizer by Hologic. This marker is a radio frequency identification device tag, really small size, approved for breast marking. In the axilla, off-label yet, and we have the same advantages, no signal loss over time. Each marker has an own ID number, but we have potential problems like very deep-seated findings may be problematic to find. And in case of multifocal disease, then you have to have a distance in between the two markers because it's quite hard to identify different markers with the same signal, and you have MRI artifacts, but these are just possible and not so severe as you have seen in the magnetic seeds. Then you have radar-based markers. So this is frequently used in the States, the Saviscout by Merit Medical. The marker is a bit bigger. It's approved for soft tissue marking for longer than 30 days. Same advantages and potential problems you have are listed here. And in case of multifocal findings, there is a renewed tool, or there's additional tools we have at the moment. You have, and this is approved in the States, different Saviscout markers with different frequencies, so they can be identified with different signals. So therefore, you are able to use it in a multifocal disease to say this is lesion 1 and this is lesion 2, and you are able to identify it via a different signals. MRI artifacts are possible, but these artifacts are quite low, as shown in this illustration. The Saviscout marker has the lowest artifact, or the smallest artifact. MAC seed, the biggest one, and the radio frequency identification track is something in between. And then you have radioactive seeds that are not used in Germany due to our radiation protection regulatory authorities. Well, this is a radioactive 125 iodine seed with a long half-life, can be detected with a gamma probe. So all these localization techniques are detected with a probe. You have the same advantages like all these markers have, and in this case, potential problems are maybe radiation protection that we have in Germany, and the signal loss over time. To summarize all these pro-based marking methods in this little case of a 70-year-old patient undergoing a biopsy, diagnosed by a left-sided invasive breast cancer, you see 12 millimeter, node negative. First presentation of this patient and the surgical planning and the marking could be done in all in once. And then the patient didn't have to come back to the hospital, didn't have to get another procedure, underwent breast conserving surgery and so on. So the advantages are the surgery can be in the first place without any problems when you think of your operation plan. So you don't have to have an additional appointment in radiology or in diagnostics in the morning of the department, or maybe the day before the surgery, or the patient has to be transported to radiology. This is far away, and disadvantages are of course costs. So I don't use this marker in my daily routine for breast. I use them for the lymph nodes because I'm not able to pay, let's say, 3 or 4 markers for one breast case. But this is something the industry has to work on to lower the costs, and I think then we have green light for all these different markers. Let us think of the process the patient is undergoing in the hospital. Then you have your first marking, as I said, so maybe before neoadjuvant chemotherapy. And then you put a clip in because you have to identify the lesion, and then you perform neoadjuvant chemotherapy, and then there's a second marking. So does it make sense to mark a marker and to bring the patient back and then performing the operation? So this is something that can be spared. So perform your marker, make your neoadjuvant chemotherapy. The marker will be still there, is detectable by a signal you are able to listen to, and you don't have these losses of markers, as you know from your clips. So we have for neoadjuvant treatment, of course, marking via clip, via coal, and then gold standard via localization, and then you have the excision. And as I said, to make it more prominent with this slide, and then this is something you can, of course, spare. Of course, caution, MRI artifacts can happen, as explained in the talk already. Yes, we do have a lot of publications, so these publications just stand for the radioactive seeds we don't use in Germany. I have no idea if you are able to use them in Turkey, but all these different publications, they tell us go wireless, go radioactive, go for radio frequency, go magnetic, but go wireless because it makes it so easy to detect, and it makes the whole process of the patient's story much better. One study that is going on that is supported by UBreast, and this is supported by Synaturk and by the WGWN and the OPBC, so every one of us is here in the meeting, is the Melody study, finding out what is the right localization, what is the right type of breast lesion for the right localization. The endpoints are listed here. The study is consisting of a questionnaire for the surgeon, for the diagnostician, and patient-reported outcomes, and of course there are like endpoints like the R0 resection, for example, but the duration of the operation, why marking dislocation, and so on. We want to know where are lost markers, so where are the advantages, disadvantages of the different localization techniques. And of course, and this is the bridging maybe to the talk of Thorsten Kühn, meanwhile, we are very successfully recruiting patients in the Axana study to get an idea what is done in the axilla, because I talked about the breast, but of course you can use the marking tools in the axilla as well, as long as they are approved. My take-home message is pro-based marking has become the standard in many countries. The comparative studies do not show any disadvantages compared to wire marking, but we don't have that many studies that compare the wire with a wireless marking. Of course, caution, there are MRI artifacts in a neoadjuvant setting, so make your thoughts before how to monitor the patients. The R0 resection rate of all techniques appears to be similar, but I think this is not the goal to decrease the reoperation rate, because I think there are other tools and there are new intraoperative margin assessments on their way, such as diffusion weighted MRI or optical coherence tomography. Well, yes, thanks for listening, thanks for interest.
Thank you very much, Dr. Thiel. The discussion is at the end of the season. Thank you.
Okay, our next speaker is Dr. Torsten Kuhn, and his topic will be localization techniques for the axilla and targeted dissection. Please, Doctor.
Yeah, thank you very much. Ladies and gentlemen, Mr. Chairman, first of all, I want to thank for the very kind invitation to come here. It's a pleasure and also an honor to be here, and specifically I want to thank Professor Cantuk for the kind invitation and the excellent organization. We had so many WhatsApp exchange, and that was brilliant. And even more than thanking you for inviting me here is thanking you for the excellent collaboration that we established with so many Turkish friends and colleagues in the field of breast cancer scientific research. Now, my topic is localization techniques for the axilla and target axillary resection. These are my disclosures. So, localization techniques for small impalpable breast lesions are well established for decades, as you have heard from Mark Till, and replacement of wire-guided procedures is increasingly gaining importance. The wire is retiring, but localization techniques for impalpable suspicious lymph nodes have been introduced only recently. There are several scenarios where we need or increasingly mark lymph nodes. There's a targeted removal of clinical occult histological proven lymph nodes in upfront surgery, and I will show you the NCCN guidelines in a minute. Certainly the most popular necessity to target lymph nodes is the target axillary resection after neoadjuvant chemotherapies for patients who present initially with a positive lymph node status, and a new indication, the forgotten node. Now, these are NCCN guidelines for upfront surgery, and as you can see here, patients who, what is the indication for sentinel lymph node biopsy? Certainly patients with a clinical negative lymph node status. But if you go into the guidelines, this was a bit astonishing for me. Patients not only with a palpable negative lymph node status, but also patients who have clinically negative nodes, but positive loads on imaging like ultrasound. You can then perform sentinel lymph node biopsy, and you have 1 to 2 sentinel lymph node positives. You can omit axillary resection. Well, we would not go probably for this strategy in Germany because we think there are not adequate data for this, but as you can see, marking lymph nodes will also be important in upfront surgery, and there's a very good study that looks exactly at this issue with the Taxis trials that looks at or examines the issue, can we remove only clinical apparent nodal disease and leave the axilla intact and then go for X-ray irradiation. So I think we need this trial before not surgically treating clinically apparent nodal disease. But much more popular is the target lymph node biopsy and target X-ray resection in patients who undergo neoadjuvant chemotherapy and convert from CN1 to YCN0. And as you know, this is certainly standard of care, having a biopsy of the lymph node, putting in a marker, and take out the marked lymph node after chemotherapy. And just to be clear for the definitions, the sentinel lymph node is the lymph node, the first lymph node to which drainage occurs. The target lymph node is a positive lymph node that has been marked with some kind of device. And the targeted lymph node dissection is the combination of the sentinel lymph node biopsy and the targeted lymph node biopsy. Now, there have been several studies going on, and we want to talk about technique. In this presentation, as you can see here, for the sentinel lymph node biopsy, the detection rate is reduced, the false negative rate is quite high. But whenever you use the localization technique of the biopsy-proven positive lymph node, you have an excellent detection rate, and you have a very low false negative rate of less than 10%. So independently whether you only, this is target lymph node biopsy, where you only remove the target lymph node, or if you combine it with a central lymph node biopsy in the targeted axillary section. Third new indication for marking lymph nodes is the so-called forgotten node. And this is a paper from Orit Kaider-Persson, who's a radiation oncologist. And what they see is in times where we de-escalate axillary surgery, and there are less surgeons experienced with axillary dissection, and when radiation oncologists do their planning CT, what they observe increasingly is a forgotten node that has not been resected. So there's a clinical need to remove this lymph node, and we have to localize it somehow. So this is a new indication for marking and removing lymph nodes. Now, what techniques are available for localizing these lymph nodes? There are three categories. First of all, there's a visual technique. We all know from the blue dye technique in central lymph node biopsy, and in this case we can use charcoal to visualize a lymph node. We inject the charcoal into the lymph node, we open the axilla, and then we find the lymph node, and the charcoal is present after chemotherapy, so we can identify the target lymph node. Then we certainly have, and this is the most popular localization technique, image-guided wire localization. And as Mark already said, there are a multitude of markers that can be used for marking lymph nodes after neoadjuvant chemotherapy. And then we have, as we already have heard for the breast, also for the axilla, we have probe-guided techniques like the use of magnetic markers or radar markers or radio frequentation tags. So this was the first paper for the use of charcoal, published in 2015 by Nicole Choi. And as you can see here, the charcoal is injected into the lymph node, and after neoadjuvant chemotherapy, you can open the axilla, you can identify the target lymph node by the charcoal staining, which can then also seen in the histological workup. So this was then tested in the tattoo trial, in the German and later international tattoo trial, published by Steffi Hartmann, and an update was published by Jana de Boniface from Sweden. And what we could show in this trial was that the detection rate for the charcoal was good, with 93.6%, better than for the central lymph node. And in the updated paper, it was even 94.6%. So there was a sufficiently high identification rate. And when we look at the false negative rate, this was also very good with 6.2%. So there is an advantage because charcoal is cheap, costs a few euro. And it's reliable. But there is a disadvantage. It's relatively extensive surgery because what you have to do, in many cases, you open the axilla widely just to get access and see the lymph node. So there is a more extended surgery to identify the stained lymph node. So the second category of lymph node marking is the use of image-guided wires. And as we have already seen, there is a multitude of markers that perform differently. And here you can see a lymph node that is then taken out, that is then located with a wire and removed. However, this wire-guided localization has the same disadvantages as we have heard from the localization techniques in the breast. And there's one important difference in neoadjuvant chemotherapy. We all use markers, clip localization for tumors, and when the tumor has shrinks or has disappeared, then we do stereotactic needle localization. But in mammography, it's easy. When the tumor has vanished, you can see the clip. You can put in a needle and localize the clip. This is different in the axilla, because in axilla we use ultrasound-needed clip needle placement. So we can see in the upfront, before neoadjuvant chemotherapy, we have a positive lymph node. We have the hypoechogenic cortex of the lymph node. We can easily see the clip in the lymph node. But when the lymph node has vanished and there's a good response to chemotherapy and the hypoechogenic cortex has vanished, so it's quite difficult to identify the clip, and therefore the technique is quite challenging. It works well in a very experienced hand. But as we could see in the CENTER trial, which was the first multicentric study for looking at the detection rate and false negative rate for the target accelerator dissection, we could see that the detection rate was only 75% in a multi-center setting. Although we know that there are centers of excellence with very experienced radiologists who have a detection rate of 100% because they exactly know where to put the needle. But this means that the reproducibility of the use of clips and ultrasound-guided localization is quite difficult and requires a lot of experience. Another problem for the use of clips is the loss of clips. And this is a paper from Steffi Hartmann, and it was among the first papers published on the clip localization. The rate of lost clips was up to 33%. And I saw just preparing this presentation, I saw a very nice paper from Neslian, who is in the room, and I saw that she described the same problem. So losing clips is a problem, what to do. And all of us who did perform the surgery, we took out the central lymph node, we did the radiography, we performed the X-ray section, we performed the radiography, no clip. So this is a problem associated with the techniques. Now, disadvantages of needle localization, there's certainly discomfort for the patients for every needle localization, and there are logistic challenges, as we have heard, for the breast. It requires high expertise of the radiologist to detect a clip after good response to chemotherapy. And this explains why the detection rates vary between 70 and 99% and the problem of lost clips. Then we have probe-guided techniques for lymph node localization. Certainly the radioactive seeds, as we have seen from the breast, using a simple gamma probes. We are very much used to gamma probes. Then we have the paramagnetic or magnetic seeds, as we have seen from the breast, using magnetic probe, and radar markers with a radar probe. Now, this is a very good study, the RESA study that was published recently in JAMA Oncology by Janine Simmons, was presented 2 years ago in San Antonio, and the Dutch group uses radioactive seeds. In this prospective multi-center study, they examined 222 patients, and the detection rate for the central lymph node biopsy, as expected, less than 90%, 86%. For the target lymph node, which is called the Mari lymph node in the Netherlands with a radioactive seed, was 94%, and in 97%, Mari or central lymph node was identified. So a very high identification rate. And when you look at the false negative rate, it was low. It was 3.4% with a confidence interval between 1 and 7. So this is a safe technique. So it's a reliable technique and easily to perform. So it's accurate, it's cheap, we don't need a needle. But there's a problem, there's radioactivity, 2 disadvantages. There's loss of activity with time, and the second one is, as we heard from Aktil, there are radioactivity protection regulation, as we have in Germany. We cannot use these techniques in Germany, but in countries where they can be used, they work nicely, and I've learned from Finland, the price was 35 euros per application. So this appears a good technique. So what about magnetic and paramagnetic seeds? This is the use of endomag system, the MAX seed system, and when we could go for the video, can you just, or can I do it myself? If not, we can proceed because it's very simple. It's like a central lymph node used with the gamma probe. You have a very precise signal using this probe, okay? And now we need, okay. So this is very much what you know from the central lymph node biopsy procedure. You have a very precise signal, and you can take out the lymph node easily. Okay. So advantages, disadvantages of the magnetic seed. Certainly advantages, again, there's no needle, it's accurate, and there's no loss of activity. So the maxi can be placed before neoadjuvant chemotherapy at the start of treatment. Certainly disadvantages, there are MRI artifacts, and there's an example, as you can see on this side. So there's maybe a disadvantage if you use MRIs, but not everyone uses MRI in the neoadjuvant setting. And as you can see here, it's quite far in the axilla, so if the tumor is not located in the upper outer quadrant, so there may be no problem. So we regularly use the seeds in the axilla, we perform MRIs, but we certainly look before inserting the seeds where the tumor is not located in the upper outer quadrant, but in all other cases, the MRI artifacts are no problems for the use of the seeds. There may be interference with pacemakers, so no metallic instruments, as you have heard, but this is no problem. But the price is certainly a problem. This is a nice paper from Peter Berry from the UK. And as you know, the approval for the seed, we only recently had approval for the seeds without time limit. And so at that time, they put in a clip, and later after surgery, they put in a magnetic seed into the clipped lymph node. And in this paper, it was compared when the seed was placed before neoadjuvant chemotherapy or after neoadjuvant chemotherapy in a clipped node. And this is quite interesting, the dislocation rate. So when you place the seed up front before starting chemotherapy, the dislocation rate is only 1.8%. If you clip it later on after chemotherapy, there's a much higher dislocation rate of 24%. So I think the best technique for marking lymph nodes with a seed is at the start of chemotherapy. So one of the important secondary endpoints of the Axana study is the comparison of different markers for the target axillary resection. The Axana study first primary endpoint is disease-free survival and overall survival, and we include 4,500 patients. You will see that we are very thankful for the very strong Turkish contribution. I will show you the numbers a little bit later on. Secondary endpoint is the performance of marker, and this is interim analysis. So in the Axana study, we have 9% use of magnetic seeds. We included, so far we placed 162 seeds. TID was performed at 128, and the detection rate was 97.6% at this stage. There was one lost marker, so this also exists with magnetic seeds. But as you can see, the detection is excellent. Very similar to the radioactive seeds. And these are the radar-based seeds. So again, advantages, no wire, transcutaneous localization feasible, no loss of signal over time. Potential disadvantages, signal intensity depends on angle. This is something important in clinical practice because the signal, the intensity of the signal does not depend on the depth of the device as we usually think. It depends on the angle of the probe to these antenna. So this may lead to problems in detection with this device in clinical practice. So signal intensity depends on angle between probe and marker. There may be artifacts as well, but Mark nicely showed that the artifacts are less in the radar markers compared to the magnetic seeds. And again, the price is a problem. So what are our experiences in the Axana study? You see the use is only 1.8%, which is mainly due to the price. We included 66 patients so far, and TID was performed in 40 patients, and the detection rate 95% again. So they're performing well. So if we compare different localization techniques in the axilla, we see for the charcoal, there's a good detection rate, more than 90%. There's no dislocation. The surgical trauma is higher. There may be skin coloration as impairment. Logistic challenges are low. There are no artifacts, and there are low costs. So it's a good technique if you have not very high resources. For the clip coil, the detection is moderate. Dislocation can appear. Surgical trauma, moderate. You need needle, which is a disadvantage. Logistic challenges are high, no artifacts, costs moderate. For the magnetic seat and radar seats, they perform quite similarly, excellent detection, low dislocation, low surgical trauma, little impairment of the patient, low logistic challenges, but we have artifacts and we have high costs. Probably the best solution nowadays, if you have the opportunity, we do not have it in Germany, are radioactive seats which have an excellent detection, low dislocation, low surgical trauma, little impairment, low logistic challenges, no artifacts, and moderate costs. So this is the situation, but to my knowledge, there are very few countries where radioactive seeds are allowed at the moment. So in summary, localization techniques for lymph nodes become clinically increasingly important. Probe-guided procedures appear superior to charcoal and wire. Radioactive seeds perform excellent. High costs and MRI artifacts are a challenge for magnetic and radar seeds. Charcoal is a cheap and reliable alternative. And ultrasound needle localization is associated with the highest discomfort for the patient and requires a high expertise and experience. Thank you very much.
Thank you, Dr. Kuhn. Our third speaker, Yazan Masanat, will be online. So before connecting to him, I would like to get the questions for the first two speakers. Please. Evet, bir mikrofon alabilir miyiz?
Shortage of the microphone, that's why I'm talking now. You did a great effort to show what you showed us a very sophisticated methods. Despite all the errors, all the results show, there is no it is not necessary to make a targeted axillary surgery if you remove only 3 to 5 lymph nodes. So our experience in our Istanbul Medical School and in Milan trials and many trials show that there is no need to targeted surgery anymore. But you still insist there is a role. What do you say?
Well, I have a second presentation on this issue on axillary surgery after neoadjuvant. So, should I answer now or later? Okay, so we come back to your question. Okay, it's an important question. It's an important question.
Okay, Levent. Still, you need a microphone, but...
Thanks for the excellent presentation. So, I was in three weeks ago, I was in ASBRS in America, in Boston, and they said there is no Bloom defect in radar-guided lumpectomy. So I'm very surprised that you said there is a Bloom defect in the MRI artifact, you said. So they said that radar-guided lumpectomy is superior than magnetic seed when they are using in the neoadjuvant setting. So I need to know your experience. So this is very important that there is a big conflict in America and Europe now. And the second question, what do you do for the lost clips? Do you do more dissection, or you are not doing anything? So there is a study in Memorial Sloan Kettering that they said, if there is a lost clip, you don't need to do anything. Thank you.
So I think the two of us will answer. So the discussion in the States, so the two of us are traveling in the States talking to the US colleagues. I mean, the radar reflector marker is the marker in the States, so this is what's used there. And what I've shown is that the MR artifact is the lowest with the Savvy-Scout system. So therefore, yeah, there is a difference. If you are monitoring your patient under neoadjuvant chemotherapy via an MRI, so make your decision before you make your marking, then of course you will have an artifact that is higher with a MACSEED or with a Pintuition in comparison to the Savvy-Scout system. So therefore, well, and regarding the procedures there, everything is paid there. So this is always something I'm very surprised. In Germany, we have the DRG system. That means we are paid for the whole procedure, and then you can spend as much money as you want, but in the end, you will lose your money if you spend it on costly technical tools. Regarding the lost clip, there is this study out there, and I mean, in the end, we don't go for an extensive axillary dissection, and we don't find the clip later on. It's not able to use a CT scan during the operation. You won't find it with a C arrow, the clip. So this is what we tried out in the very first beginning. So therefore, if you don't find the clip and you made a good job, then in the end, it's done. So this is what I think. Thorsten?
Thank you very much for the nice question. The first question related to breast or axilla, or both? Both. Okay, I think for the breast we can say, to my knowledge, there's one big study from the IBRANET that compared MACSEED and wire. And this was a big study. So there's no big study, to my knowledge, you can correct me, between the Savvy-Scout and wire and comparison between MACSEED and Savvy-Scout. So this is evidence. So regarding the axilla, he's the expert.
No, I'm not the expert. Just to put some things into context. It is exactly as Thorsten said. So I don't think that we will ever be able to reach the level of big data in the fashion of the IBRANET or randomized control trials like we did with the MACTotal that is going to be published soon. So this means that we have to kind of extrapolate and make indirect conclusions. With regards to your question, I think that the necessity, how much of a problem a blush on an MRI is, has little to do with how you plan to do surgery. It depends on how much you feel you need the MRI. Now, the evidence there is not conclusive. So we know that the MRI has its uses both in the upfront setting and in the neoadjuvant setting, but evidence-wise, it seems that we are using it without very clear benefit on that.
Is 3 centimeter bloom defect has. In radar-guided lumpectomy, like 2 or 3 millimeter, but in the MACSEED, it has 3 centimeters. So this is very important for the patients who's going to treat it after neoadjuvant therapy. Okay.
Regarding the systemic treatment, so you know Germany is a country of neoadjuvant patients, and we don't use an MRI very frequently, for the matter of fact that it really doesn't have the loss of the contrast agent enhanced.
just so. Okay, let's. Dr. Masanat is waiting, so I will just give one comment to Nes. Okay, just a short comment.
Okay, thank you very much for your excellent presentation. My question is to Dr. Kuhn. How is your practice to mark the suspicious lymph nodes when you use the radioactive iodine seed 125? Because there are some concerns in United States about the timing. Do you mark using radioactive seeds at the initial chemotherapy or just before the definitive surgery to reduce the time to exposure to the radioactivity?
I think it's a very good technique. Not radioactive. So we cannot use radioactive seeds in Germany. That's our problem.
But in Dutch trials, they always use for 3-4 months. So they say it is safe, but in United States there is a discussion about the safety.
We have this discussion hearing. Yeah? I think it's okay, the discussion, because if you look at the research trial, they used radioactive seeds up front, but there was also a loss marker with the radioactive seeds. This may be a problem.
Okay. Okay, thank you very much. Now we may connect to Dr. Yazan Masanat, and he will today present us the new localization techniques, especially the UK experience. Welcome, Dr. Masanat. Can you hear us? Okay. Now you may start, I think.
Can you hear me at all?
Yes, now we can hear you.
Hello.
Can you hear us?
I can hear you very faintly.
Okay.
But if you can hear me,
Yeah.
give me the thumbs up and then I can start sharing the slides.
Yeah, you may start.
Andreas, text me. That's great. So, Vadir has texted me and told me that we can hear you perfect. That's great. Many thanks for the invite, and apologies I cannot be with you in person. And many congratulations to Prof. Zakir Jantur for being director of the university. So Andreas is texting me to say don't shout. I'll try to make my voice a bit less loud. So I was asked to talk about new localization techniques in the UK experience in this 7th International Breast Mayday, and thanks for that invite. I'm one of the surgeons in Aberdeen. I sit on few committees in the UK and Europe. And my disclosure is the iBreast book. As I run webinars, we're starting to run some in-person courses, hopefully in July in Aberdeen. And some of those are sponsored by some of the companies. Some of them are some of the localization companies, but there is no conflict of interest regarding this talk. Apologies, I couldn't hear the previous two talks because I'm not connected here. So there will be a bit of repetition, and I'm sure there were two great talks by Thurs and Mark. So the new localization, remember that breast conservation is relatively new thing. It's only been there for the past